Well, good afternoon to everybody joining us. Thank you for coming to our monthly Science Cafe. My name is Laura Parent. I am the Director of Strategic Partnerships and Research Development at the CTSC of Northern Ohio. I'm filling in for Mackenzie Rittner while she is off. And so thank you all for joining us. This month, our topic is cardiac arrhythmias with Dr. Tereshchenko. And first, I would just like to provide a quick overview of the CTSC of Northern Ohio for those of you who are not familiar. But our goal is really to improve the health of people in Northern Ohio and beyond by providing resources and services to our hospital and university partners, our clinical and translational researchers, and our community members. We're doing that through 5 key areas and initiatives like resources and services, our vouchers and funding, community engagement, workforce development, and our health informatics. And today we have a speaker with us, Dr. Tereshchenko from the Cleveland Clinic in both the Department of Cardiovascular Medicine and the Department of Quantitative Health Sciences. Her research interests include studying the mechanisms of cardiac arrhythmias and the effects of cardiac arrhythmias within the cardiovascular disease continuum and developing cutting-edge tools to advance the prediction, prevention, and treatment of cardiac arrhythmias. And I'd like to turn it over to Dr. Tereshchenko. Thank you so much for being here.
Well, thank you so much for that opportunity to present, and I want to thank CTSC for funding my study. I received pilot funding, and I'm very grateful for that. So I think it's a wonderful collaborative group, and I am happy to present research in my laboratory, and I am open to discussion. I guess that's the point of presentation. So we'll have discussion, and if anybody has question, you are very welcome to ask questions. I don't know how, Laura, housekeeping item, how do you suggest if people have questions, do you suggest they type it, or we will go through discussion after? How do you suggest we do that?
All are welcome. Feel free to drop your questions in the chat while Dr. Tereshchenko is presenting. And of course, and towards the end, we'll have the opportunity for open discussion.
Okay, thank you. Okay, we are going to talk about sudden cardiac arrest first, and then about certain electrical biomarker of risk of sudden cardiac arrest, and then our approach to find new future hopefully cures, new treatments of conditions underlying different cardiovascular conditions which are probably underlie risk for sudden cardiac arrest, and we'll discuss how we can advance science and improve outcomes in patients at risk of cardiac arrest. So first, let's see who attending our group meeting. So there is a question to you. What arrhythmia is the most frequent cause of sudden cardiac arrest? And there are a few choices. It is ventricular fibrillation, asystole, pulse electrical activity, or atrial fibrillation. What do you think is the most frequent cause of sudden cardiac arrest?
The poll is open. Feel free to participate. It looks like we're kind of split between ventricular fibrillation and atrial fibrillation.
Okay, very interesting. So I have work to do. Wonderful. Do they see answers? Do audience see, or they don't?
Yes, they see. They should be able to see right now. About 55% say ventricular fibrillation.
Okay, there is a hold there.
If you click the polls, you should see that. Okay, so there's the results, if you can see them.
Wonderful. Wonderful. Okay. Yeah, so we have a split. Okay, so there is the hopefully I would be curious, maybe can we, I don't know, repeat at the very end of the same poll? This
Sure.
one, just this one. Okay, thank you so much. It's very interesting. Thank you for that opportunity to have a interactive presentation. Okay, so first we'll talk about sudden cardiac arrest. By the way, October is Sudden Cardiac Arrest Awareness Month by American Heart Association and Heart Rhythm Society. It is tragic event, and in this kind of compilation of basically different messages, you can see that it is especially tragic to see when otherwise healthy person, especially young person, you probably all heard stories from athletes, especially when televised, highly attended event, and when otherwise healthy person being like athletes competing in a sport event suddenly drop dead, and it is definitely tragic, and it should not happen, right? But unfortunately, sudden cardiac arrest is very difficult to predict, and that's why we do our research. Underlying cause of sudden cardiac arrest is cardiac arrhythmia. That's why it is important to find those people who are at risk, because there is something which we can do nowadays to prevent sudden cardiac arrest. Otherwise, if it happens in a person who would not be considered at risk, the only hope is to have cardiac defibrillator available in a short proximity and have somebody who can do CPR, cardiac pulmonary resuscitation. And it is by chance, depends where that cardiac arrest happens. So, it's difficult to address. So sudden cardiac arrest is electrical system malfunction. It's a cardiac arrhythmia. So underlying mechanism is cardiac arrhythmia. It is a leading cause of death, and unfortunately, in the last 20 years, there is no improvement, and we still have the same rate of sudden cardiac arrest in this year as it was approximately 20 years ago. And so there are three types of arrhythmia which can cause sudden cardiac arrest. The most frequent one is ventricular fibrillation. So ventricular fibrillation remains to be the most frequent arrhythmia which cause sudden cardiac arrest. It is not atrial. So there is an atrial fibrillation is the most frequent arrhythmia, period. It is the most frequent arrhythmia in the population. But people with atrial fibrillation thankfully can live long life, right? So it is a risk factor, but people who develop atrial fibrillation don't immediately die from it. It is upper chamber fibrillation, and if ventricle is doing fine, not every activation from atria propagate to ventricle, and that's why patients with atrial fibrillation don't immediately die from it. But those who develop ventricular fibrillation die without resuscitation in a range of a few minutes. 10 minutes is a time before brain death without circulation. So that's the timeline. Asystole is the second most frequent cause. Asystole when heart is not, there is no it's a straight line on electrocardiogram. There is no electrical activity in the heart. And it can be rescued. So ventricular fibrillation can be rescued by defibrillation. There are defibrillators. I have pictures on the next slide. But asystole can be rescued by pacing. So if, for example, if patient has a device, pacemaker, and it can pace, that patient can be saved, life can be saved. There are certain devices which can be which can deliver transcutaneous pacing, and it can be done as a part of resuscitation by emergency services. That's why calling 911 is the first emergency step, right, to save a life. So ventricular fibrillation and asystole can be rescued and resuscitated. Pulseless electrical activity is a condition when patient develop some dramatic event which cannot be rescued by like any electrical therapy. For example, it is a rupture of, so patient who develop very large myocardial infarction and it is transmural through all like walls and heart literally rupture, and blood goes out of heart like in a pericardial space. Have a patient develop tamponade, and the only way to save such patient would be to do immediate open heart surgery. But you can imagine if it happens out of hospital, there is no time to have surgery available right there in a range of few minutes, and unfortunately those patients usually cannot be saved if it happens out of hospital. So the way how it is now approached, obviously risk factors. So this is from American Heart Association, Heart Rhythm Society. This is how clinicians right now approach risk for sudden cardiac arrest. So obviously, if a patient has known cardiac disease, so having cardiac disease put anybody at risk for sudden cardiac arrest. And coronary heart disease is the most frequent one, cardiomyopathy, structural heart disease. So if patient has heart disease, patient undergo treatment, patient is taken care of by cardiologist, and those patients actually have better chance of survival. Knowledge of having cardiac disease is actually protect patient from cardiac arrest. So kind of, it may sound paradoxical, but as soon as patient knows that his or her heart has some problems, then patient may think about that and call 911. It was demonstrated in Oregon Health study when, again, knowledge of having heart disease help to save patient life, just because if something, patient feels something, patient call 911 right away, compared to those patients who believe that they are healthy and they may not consider that slight discomfort in the chest, maybe because of heart. They ignore the symptoms and don't try to call 911, don't try to reach, and they have high risk of dying from sudden cardiac death. Family history, very well-known risk factor, and it is, and this is how essentially, so we continue that line of research. Again, it is very well known that family history is important predictor of sudden cardiac arrest. And but not every patient with a family history has a genetic defect which can be successfully identified. Inheritance of arrhythmias, very complex area of research, and there are so much unknown. And research in my laboratory, which I hope to show later, is addressing exactly that risk factors. So there is a family history component. And the last risk factor, lifestyle, obviously is very, very important. And there is no question about that. So as soon as we all live healthy lifestyle and recommend our patient to maintain healthy lifestyle, we all reduce risk of cardiovascular disease and including sudden cardiac arrest. So very few, very dramatic facts. Only 50%, so like in the 50% of patients who die suddenly are not aware of the disease. Again, it's a kind of like knowledge of cardiovascular disease is a power. And in a 50%, in half of victims of sudden cardiac arrest people are not aware of having cardiovascular disease. So I think it's a dramatic number. So if we do better screening of population, and that's why it is called sudden cardiac arrest, right? So sudden, nobody expects that patient would develop. So otherwise people may feel perfectly fine, no symptoms. So we have to develop screening in order to identify those who are at risk, and sort of that definition of sudden cardiac arrest, completely unexpected event, which is tragic, and death, when death is the first manifestation of cardiovascular disease, it highlights the problem of not diagnosing cardiovascular condition before death happened, right? So there is a big room for improvement overall. And another striking kind of piece of data is that in patients who are successfully resuscitated in a field, who brought to hospital, who are hospitalized after, that is how it happens. So if sudden cardiac arrest was witnessed by somebody, and resuscitation started, patient is rescued, like shock delivered, patient survived, got resuscitated, brought back to life, and that patient admitted to hospital. And at that time, all diagnostic procedures is done, all cardiac imaging, coronary artery condition, presence of coronary heart disease, which is the most frequent cardiac disease, any other genetic cardiomyopathies, channelopathies, everything, all known tools. When we exhaust our diagnostic capabilities, 30% of those who develop cardiac arrest survive cardiac arrest, and then after trying really hard to find cardiac condition, 30% remains to be unknown, which is another dramatic number. Meaning we just don't understand, we don't know, we cannot detect more likely channelopathy or cardiomyopathy, which can manifest as sudden cardiac arrest, but we just don't know what exact gene abnormality goes into that condition. So that's another motivation for our research. So that is a modern framework of how we so far approach trying to prevent. Obviously, because it is a tragic event, we want to prevent that event, right? So we advise people to maintain healthy lifestyle, have a healthy diet, exercise, have follow-up with primary care physician to make sure that risk factors are addressed, such as hypertension, diabetes, and like all traditional healthy lifestyle like recommendations. If patient is diagnosed with cardiac conditions, then it has to be taken care of and treated. And another, considering awareness of sudden cardiac arrest risk, we should promote access to defibrillators, external defibrillators. And that is another important measure which demonstrated to be successful and making a difference, right? So automated external defibrillator they are installed in the public places, in airports, in a big facilities, in a sport facilities, and recently, if I'm not mistaken, actually there was a quite a good. So our Congress actually there was a law which went into effect, and I apologize for not being able to cite it exactly. I'm not expert in the Congress. But I remember we actually celebrated because there was a group, advocacy group, trying to make automated external defibrillators more accessible. Yeah, they should be present in a large sport event at schools to provide opportunity for timely resuscitation, because time what is crucial in order to save a life. And another important public measure is to train in CPR, in cardiopulmonary resuscitation, which is initiative which is championed by American Heart Association, and there are different opportunities for people to be trained. And I think we have to continue to spread awareness, promote education, to ensure access to life-saving resources which can prevent and provide timely response to sudden cardiac arrest. So that's what we can do. But let's say patient is saved on a field and hospitalized, right? So the next step is to survive hospitalization and be discharged from hospital. Unfortunately, and this is very dramatic number, it's another dramatic piece of information, only on average 10% of those patients who are saved and rescued on field by emergency medical services, only 10% of them are discharged, being survived from hospital. It is again like very striking number. So even being resuscitated in a field, not enough patients unfortunately don't survive to discharge. And that highlights again crucial timeline of cardiac arrest treatment, and the importance of prevention rather than treatment. So treatment is difficult, and if patient underwent, if there was no circulation of brain and important organs, kidney and heart, then those organs don't survive without circulation for a long time. So that's why mortality remains extremely high. So our goal is to develop better prediction and prevention of sudden cardiac arrest. So that's what we are trying to do in my research laboratory. So the way how we do it, we are trying to develop electrical biomarker. As soon as it is an electrical problem, we try to develop predictors of arrhythmias looking by condition of electrical system. There is a second poll to you. What is vector cardiography? It is it, I don't know, so not maybe all of you heard about that. Is it a method to measure cardiac mechanical function, method to characterize electrical activity in 3 dimensions? Is it a method to calibrate cardiac MRI and cardiac CT? Or is it artificial intelligence method? Because nowadays everything is artificial intelligence, right? Intelligence become artificial.
Okay, we've got about half the people reporting so far. We'll just take a couple more seconds. All right, and here's the results.
Wonderful. So this is much better. Like, yes,
Much better.
this is much better, this one. So it is electrical. It's a method to characterize electrical activity. Okay. So vector cardiogram and electrocardiogram were developed at the same time. It was 1930s, so it's 100 years ago. Both methods, electrocardiography and vector cardiography, which is essentially the same method, those methods are based on assumption that heart is the electrical vector. It is oversimplified assumption that entire heart is assumed to be dipole vector, and that vector is moving during cardiac cycle. So projection of that heart vector on a particular lead axis over time, if you do that, if you kind of project heart vector and kind of like record how that goes over time, you will see electrocardiographic waveform, PQRST, right? But if you look at the movement of the heart vector overall, if you look at every single point in time, how heart vector is moving, you will see loop. So you will see vector cardiographic loop. So vector cardiographic loop is a presentation of heart vector movement over time in three-dimensional space. And projection of that heart vector on a particular lead axis, on one lead axis, is electrocardiographic waveform. So it's essentially exactly the same. It is just a different way to record heart vector movement, either by recording electrocardiogram or by recording vector cardiogram. It essentially is exactly the same. But vector cardiography has advantage because we are collecting all information during cardiac cycle, and recording electrocardiogram is a reduction of that information because we are looking only at one lead. And apparently we can look at 12 leads. That's what clinically used 12 lead electrocardiogram doing. We are recording projection of heart vector on one particular lead, and we use 12 leads. So 12 leads give us more information than one lead, obviously, but it is still redacted information. So it's not entire universe of all three dimensions. That's what we do when we look at vector cardiogram. And so in 1930s, Frank Wilson is the one who came with the idea to record chest leads V1, V2, from V1 to V6. And he came with the idea to measure areas under the curve under QRST waveform, and he defined notion of ventricular gradient, special ventricular gradient, which is a three-dimensional vector which points direction along which non-uniformity of total recovery time is the greatest and duration of that time is the shortest. So it may sound complex, but essentially it reflects even in healthy heart, there is always difference between right and left ventricle, between base of the heart and apex of the heart, between endocardium and epicardium areas. And those differences create gradient. So as soon as there are differences, there is a gradient. And that gradient is usually aligned with the long axis of the heart, and it is perfectly normal phenomenon. In a diseased condition, that gradient vector points toward diseased area. And the way how it is again, the rotation, it points to the shortest action potential or shortest duration of total recovery time, from the longest to shortest, and essentially amplitude of that gradient also changes. So that's how we can capture that. And the most interesting thing is that we can do it using 12 lead electrocardiogram. We transform 12 lead electrocardiogram into vector cardiogram to have homogeneous presentation of heart vector in all three dimensions, and that's how it looks. So this is, if you follow red color, so activation starts from red, that's how it moves. So that is activation of ventricle, it's a QRS. Red color is the activation of ventricle QRS loop. And from that repolarization continues, so it's a green color is repolarization or T loop. And interestingly, if we take vectorial sum of QRS vector and T vector, we can calculate special ventricular gradient vector. So we can calculate and measure its direction, how it is directed. Does it goes up? Does it go down? And we can measure how many degrees it goes to the right, to the left. And that is reflected by measuring azimuth and elevation of those vectors. So we geometry rules very simple geometry rules to measure angles in those vectors, and importantly, we can measure special ventricular gradient vector, and we can calculate direction of that vector. And for the purpose of today's talk, we can also measure angle between QRS and T vector. So angle between activation and recovery, between depolarization and repolarization. And that angle shown to be predictive for cardiovascular disease and different conditions, including sudden cardiac death. So that is a list of investigators which did a lot of studies in basic electrophysiology and showed importance of ventricular gradient concept, fundamental properties of that. So it has biophysical properties reflecting cardiac electrophysiology. And there was a large body of research, which I am not focusing right now because we don't have time. But our group and many other groups showed that QRS to T angle specifically is associated with sudden cardiac death, with ventricular arrhythmias, with heart failure, and with many other important clinical outcomes. So it's no question at this point. It is very important electrical biomarker. So, like, we are trying to answer question how we can identify those people who are at risk of sudden cardiac arrest if nobody knows. If people don't have any symptoms, they don't have diagnosed cardiovascular disease, and yet they still drop dead suddenly, right? So we want to find those who are at risk. So the approach which we take, we look at the biomarkers of sudden cardiac arrest. We look at electrical biomarkers of sudden cardiac arrest. And then we look at genes and genetic polymorphisms in people who have a range of electrical biomarker phenotype. That's essentially how we do it. And it is a quite standard approach nowadays, genomic approach to uncover genetic architecture of different cardiovascular conditions is widely used, not just by our group, by many others. And we use exactly the same approach. So I will next talk about genetic architecture and possible underlying biology behind electrical biomarkers of sudden cardiac arrest. And so I am very fortunate to be part of a very large collaborative group. I published two genome-wide association studies. One first study I did by looking at two cohort atherosclerosis risk in communities and cardiovascular health study in 2018. And then we went to consortia, several consortia, which include European and American cohorts, South American cohorts, very large consortia, overall like more than 150,000 participants. That is statistical power which is necessary to find genetic polymorphism associated with phenotypes. So those two studies, I was first author on the first one, but then I was a senior author on the second one, which was published in Nature Communications in 2023, and that's what I will focus my presentation on. And in this study, we looked at genome-wide association study of QRS to T angle. So I presented three-dimensional vector cardiographic QRS to T angle, but it can be also measured just on one frontal plane. So frontal plane is essentially one, like two-dimensional plane. When you look at person, like, so frontal plane, I think everybody are familiar with that. So a regular 12-lead electrocardiogram, that's how it looks in a report, like any clinically available 12-lead electrocardiogram report, P-axis, QRS axis, and T-axis. And one can subtract QRS axis from T-axis. So for example, in this case, 20 minus 10. In this case, frontal QRS to T angle in this particular example will be 10 degrees. So you just take QRS and subtract T. those two numbers, and that's how you get value of frontal QRS angle. Obviously, there is a limitation in calculation of frontal angle, because you can imagine that heart vector can be rotated from anterior to posterior, and then you would not have, if you just measure frontal angle, it can be very, very narrow on a frontal plane, but because those QRS and T vectors will go far apart in anterior posterior direction, then you would not capture that, right? So two-dimensional frontal angle has a big limitations compared to three-dimensional spatial QRS angle, but it is easily available and reported immediately right now, like right away. So that's advantage of it, kind of like. So we looked at both. We looked at spatial and frontal. And this is how it's kind of basically showing three-dimensional. If you have three-dimensional angle, if you will have all three dimensions in vector cardiographic loop and measure. And so this is narrow angle, and this is wide angle. So that's essentially, that was our phenotype in genome-wide association study, which we did. So we conducted multi-ancestry genome-wide association study and included all available ancestries, European, Hispanic, and African ancestries. So our phenotype was two types of QRS angle, spatial and frontal. And we aim to identify genetic variants. We used 1000 G panel of genomic data. We did traditional statistical analysis. We normalized phenotype. We adjusted for important covariates such as age, sex, RR interval, heart rate is important. We also adjusted for height, body mass index to adjust for potential confounders. We adjusted for QT interval and paid especially attention. We paid actually a lot of attention to make sure that we are capturing something new. Before our study, there were several large genome-wide association studies of other electrocardiographic phenotypes, such as QT interval, QRS duration, PR interval, heart rate. Everything was already done. So we asked question, can QRS to T angle add anything new above other studies which conducted GWAS of similar but traditional phenotypes of electrical like substrate. So we found 61 loci, 61 polymorphisms in genetic loci associated with spatial QRS angle, which is quite a substantial number, and only 11 in frontal angle, and I can tell right away. So again, this is example how increase of statistical power does not increase, like does not bring adequate improvement of your study, because we had 158,000 of people contributing to GWAS of frontal angle, and only 111, so it's 111,000 of participants contributing to spatial QRS to T angle. And so you would like, so it's a definitely smaller number, but we had so many more findings from spatial rather than from frontal. And it is a illustration of like again, like if you measure phenotype accurately, which represent underlying biophysical phenomenon of electrical properties, then you are getting much better, much more important result compared to if you measuring, for example, frontal angle has a big limitations because it's just two-dimensional, not three-dimensional. And that's important to consider. I guess I'm trying to say, if you have a poor noisy measurement of your phenotype, it's not good. And And we had so ancestry-specific finding. Most of our population was European, and which is consistent with findings. So 51 loci were found in the European population, which is also expected, right? We found that heritability of those phenotypes, those ECG traits, was low, and it is consistent with other data reported by other ECG traits. So, like, it is what it is. It's yeah, I guess I will not comment more. But another, like, yeah, the heritability is relatively low. That's what we found. I guess it is a room for improvement both in our in measurement of phenotype as well as in measurement of genotype. So it was there is room for improvement in to answer the heritability question. There was a lot of attention, a lot of question to our group, whether we advance science beyond traditional ECG traits. And we looked both at genetic correlation as well as classical phenotype correlation. Obviously, correlation between spatial and frontal curiosity angle was important, but otherwise correlation was quite low. And I guess I have to move faster, consider I'm just looking at the time. Laura doesn't show me any. So we did a lot of traditional bioinformatics work. We looked how, so after we identified genetic loci, we started doing bioinformatics work, see what those findings can mean, what is underlying biology. And so we found that those loci which we identified are expressed in ventricular and atrial myocytes, which confirmed that heart is the main organ affected by those potential genes. So this is a complex diagram showing how different association of our phenotype with different other ECG phenotype, PR interval, heart rate, QT interval, JT. So there is a range of findings of common genetic variants which were identified by our GWAS as well as previous GWAS studies of different ECG phenotype features. Very interesting FIVAS findings. We found that so there is obviously pleiotropic effect. Looking at phenome-wide association scanning, we found association with atrial fibrillation, found association with obviously bundle branch blocks. Some interesting, such as actually chest pain. There is a publication of painful bundle branch block when people develop bundle branch block, which is associated with pain, and very detailed study of coronary heart disease with angiographic studies, including functional studies, do not support that those patients have coronary heart disease. So there are several reports which confirm that patient can experience pain even just from development of conduction abnormality per se, which has a special title. So you can search for not painless, painful bundle branch block. So which I think we also captured in this FIVAS. Interestingly, polygenic risk score was associated with the development of bundle branch block in UK Biobank data. So we demonstrated that as well. There was like another question we were trying to find. We did Mendelian randomization with particular like cardiomyopathies, such as hypertrophic cardiomyopathy, and we did not find. So curiosity angle is not causal for hypertrophic cardiomyopathy, for example. Yeah. And so it is just a summary to wrap it up, to give time for discussion. It is just a summary of findings. Obviously, it is very exciting to look what those genes which we identified can be potentially involved it is speculative at this time. It is association in order to prove that whatever particular polymorphism is indeed is causal for sudden cardiac arrest. There is definitely more studies has to be done by basic like electrophysiology and experimental biologists in order to prove the whole path. But we did found important potential factors which involved in calcium signaling, which is a very well known mechanism of arrhythmogenesis, and a lot of potential genetic targets are known to be involved in development of cardiomyopathies, development of arteriopathies, development of different like channelopathies as well, sodium channel, calcium channel. So we found all those loci. That's another presentation. So those which are involved in inflammation pathways, cardiac remodeling. Cardiac remodeling for sure extremely important. Yeah, so we found those. This is our summary figure from manuscript, and we identified genes and pathways which are involved in cardiac development, in muscle cell differentiation, in cardiac contraction and hypertrophy, and that is the future. So we provided a lot of data for next step, which should be taken by basic scientists, taking our findings into future drug development, right? So that would be the next step. So why we are doing what we are doing overall? We hope that our study provided new insight into genetic determinants of electrical substrate of sudden cardiac arrest, and we can use that for future prediction, personalized care and personalized prediction. If we can do that in a clinical settings, right? We can also hopefully develop new therapies if those genetic variants can be targeted, and if development of interventions which alter those genetic defects can potentially be developed, right? So it's a druggable genome. Can we develop new pharmacological cures for those conditions? And implications for, again, for early diagnosis and for better treatment and development of cures of conditions, which we still have to learn what exactly is it. But it is very exciting new area of research for sure. And so that is that. Thank you so much for your attention. And how do I go from that? I guess we can stop here. Thank you so much, and I am open for questions.
Thank you so much, Dr. Tereshchenko. We are available for questions. If anybody has any questions currently, you can unmute, you can put them in the chat. I guess I'll start too, though. I had a question, what is kind of the I guess biggest hurdle or roadblock into ensuring that some of these research findings, translate into effective interventions?
Yeah, so it has to be a big, so it is multidisciplinary project. That's excellent question. Thank you so much. It is a multidisciplinary, very collaborative work. And I'm very fortunate to work with a big, so first of all, we need to assemble big data in order to even to be able to answer those questions. It is by definition big study of big, of multiple, multi-center, multi-cohort collaboration. You need to collaborate with the different specialties, right? So I developed collaboration with geneticists and genomic experts who have different models, because the next step would be to develop experimental model in order to search for, well, nowadays we definitely, people use more and more AI and try to find how changes of certain genetic properties and genetic polymorphisms can resultant change of proteins. So I have to put asterisk in our finding because no of our polymorphism actually coded protein, right? So it's not coding polymorphisms which are not coding proteins, which is expected, and that's what you usually find in a general population. Otherwise, we would not be able to find. Yeah, so it's a like long answer. It's both statistical power for rare mutations as well as for we didn't have power to find rare mutations and protein coding variants, right, in this particular study. And actually, those people who develop dramatic manifestation, they usually don't survive until the population which was included in our studies, which is 45 and above, right? So if somebody has dramatic genetic defects, they would be unlikely to survive until the moment when we draw blood in general population. So that's another consideration. But I guess the short answer, yes, we need to develop collaboration, and that's what we did. So that's the barrier. And for that collaboration, I would say support of NIH is extremely important, and I am very grateful to NIH. All those cohorts are supported by NIH for so many years, and I'm enormously grateful to many people who continue basically follow-up continues for the life, for professional life of those people, right? If you think about that, 25, 30 years of follow-up in ERIC, for example, Framingham has several generations, Framingham study. Those longitudinal studies contributed to the data which I used, and it's without support of NIH that would be literally not possible. So it is important component to build that large data which permitted us to use it and do our analysis.
Yeah. There's a question in the chat. What are typical mean values for the QRS-T angle in a ventricular cardiogram of healthy versus high-risk individuals?
40 degrees, I would say, like 20, less than 40 would be mean. I would say probably like 60 and above may be already questionable. Yeah, so below 40 would be normal. But there is a range, of course. We looked at recently using latent variable analysis, latent clustering. We looked at we looked at 5 metrics of spatial ventricular gradient, not just at angle, but also azimuth elevation, magnitude of spatial ventricular gradient, and QRS-to-T angle. And did latent profile analysis. We did it in Hispanic study of Hispanics. So it is Hispanic study population. And the most narrow QRS-to-T angle was not the healthiest one. It looks like intermediate values of QRS-to-T angle it had the best outcome. But those who have very narrow or those who had obviously wide, they had worse outcome.
Great, thank you. Any other questions from the crew?
Can we maybe ask to answer, so maybe people are shy, but can we ask that first question one more time? Or do we have questions? Yes, I think we have maybe questions.
Hi, Dr. Tereshchenko. This is Shannon
Yeah.
Spakowski, Executive Director of the CTSC. Congratulations on completion of your pilot and your studies here as well. My questions kind of center around, the translational science and the benefits of what you're doing and your research, as well as kind of your next steps. So, if you could generalize some lessons learned that this work could apply to anyone else doing any other translational science work, maybe not cardiac, but something else. But What could you say about some of the like lessons you learned or barriers overcome or any other, kind of translational question that you answered during your research that some other person could use in their studies as well? And can you talk about what your next steps might be?
Thank you so much. That is excellent question. So I think it's a very translational research, and there are so many components. My next step, I received actually I received 13th percentile on R01. So it is 13th percentile. It would be fundable in 2024 when pay line was at 14th percentile, but unfortunately in 2025, pay line dropped to 12th percentile. So I am 1 percentile above pay line. And study section was completed, but council not yet. So I still have my chance, but I don't know the outcome. So again, so my next step is to obtain NIH funding, and I'm very hard working on that. But overall, it is very translational project. So absolutely. So we want to disseminate our knowledge. We want basic scientists to take over those our genetic hits which we identified, and we make like dissemination of our findings. I am not in a position to start doing basic science experiments, but I hope that somebody will. And I know that there are examples. One example in the cholesterol treatment, the most one, like well-known one, when GWAS findings made it to pharmaceutical industry as a treatment of cholesterol. There is at least one drug which was developed. So the pipeline of translation would be to find genetic polymorphisms which can be like first identified the one which is actually coding protein, and then find target which can be druggable, and then develop drug, and then take the drug to patient cure, that would be the pipeline of translation of our findings. But we also translate in order to start looking at certain phenotypes. The way how I approach it, I look at basic science, what was done by other people, and to find, like, in order to find phenotype which we would measure on electrocardiogram, which would have potential electrophysiological meaning and has behind important electrophysiological phenomenon. So I translate from basic science into my research by looking at and see what should I measure in order to find meaningful target for GWAS. So the translation is super important, back and forth from basic science to clinical, and all those studies which I do is essentially like epidemiological in a way, right? It's a big population which is epidemiological research.
Great. Well, thank you so much. We are just about out of time. And so I want to thank you so much to Dr. Tereshchenko for sharing your research with us today. And we look forward to seeing where this goes in the future. You'll receive a survey in your email if you would like to recommend future topics for Science Cafe, and let us know how you felt about this session. Next month, our Science Cafe is on November 13th, talking about clinical trials and adaptive designs. And of course, become a member of the CTSC to stay up to date with our events and funding opportunities and more training. So thank you so much, everybody, and have a great afternoon.
Thank you. Thank you.